Welcome back. My next guest is Dr. Owen McGonigle, who's Bluegrass Orthopaedics, and your specialty is sports medicine.
That's right.
And with sports medicine, we hear a lot of knee injuries, and we hear the term meniscus. What's that mean? What is a meniscus?
Yeah, so meniscus is a cushion. We actually have two, one on the inside, one on the outside part of our knees, and they work essentially as a shock absorber with the goal of protecting the cartilage, which lines the femur and the tibia bone, which make up the knee joint.
So it's like a cushion to keep yourself from hurting yourself. So when you hurt your meniscus, what happens?
Yeah, so there's a lot of different ways, and we see this injury in a lot of different age groups. The most common one I see is more of what we call a degenerative tear, and usually it's something that can happen over time. Some people will have an acute event where they remember something happening, they got up too fast, twisted. Usually it's kind of a lower energy mechanism we describe, not something you fall off a ladder, but something that you do all the time, but this, for whatever reason, that one time leads to pain and a tear. There are other people that come in that just say, I don't really know when it started. It's been going on, gradually getting worse over the course of weeks or months, and that usually is related to just a kind of a gradual degeneration of that meniscus with time.
So what kind of symptoms might you have that would think, oh, I got a meniscus versus arthritis or strain or whatever?
Yeah, and sometimes it can be difficult to differentiate them, but from a symptomatic point of view, people that have what we call unstable meniscus tears, one that would catch and pinch and grab, they typically describe pain along one of the joint lines, either on the inside or the outside part of the knee. Things that would cause that meniscus to pinch and grab, like squatting, twisting with the knee, or changing directions, or increased activity in general, will for a lot of people cause sharp stabbing pain on the inside part of the knee. People that kind of avoid those activities might have periods where they have no pain even for days or even weeks until they kind of pinch and grab it again, and those can flare up symptoms within the knee.
Are there any activities or sports or maneuvers that make you more prone to a tear?
Just like those things that I'm describing might cause a pain with a knee that already has a meniscus tear, those things tend to be the most common mechanism. So like a twisting or a deep squat might be the things that are most likely to cause a tear. I do see them quite frequently with other injuries in a younger age group as well, such as with ACL tears or other ligament injuries around the knee that has a higher energy mechanism, so it's possible with that as well.
So how do you make the diagnosis? How do you know you have a meniscal tear?
So a lot of it is the history, what the patient might tell to me. A physical exam, kind of trying to do things that might bring out symptoms of a meniscus tear. But ultimately, if we have high enough suspicion, we want to get imaging, and that would be things like x-rays, which would look for other problems like arthritis is the big one. And then an MRI is the best way to really visualize a meniscus and see if there's something that's torn there.
Well, one of the things I, as a family doctor, wonder about is how quick do you go to an MRI? It's not an inexpensive test.
Absolutely, and again, it's a big question, because if in one patient, if I think there's an ACL tear, well, I'm going to get that right away, and you might find the meniscus. But for the more typical one that I described earlier, in more of maybe a patient more in the middle age or older that's more degenerative, I usually go with a trial of non-operative treatment for at least 6 weeks, if not even up to 3 months, before considering doing an MRI. I really want someone to try to do things that will decrease inflammation in the knee. That's activity modification, sometimes anti-inflammatory medications. And if the symptoms are bad enough, sometimes we even try something like a cortisone injection into the knee to try to get that to calm down. Those people that fail those treatments will go and get an MRI. If there's something like a complete block to motion of the knee or some other something else that tips me off that might be we need to treat it sooner, then I sometimes bypass some of those steps. But the typical one is after a series of non-operative treatments.
You mentioned some non-operative treatments, but there is an operative treatment too.
Yes.
When do you elect to do that? Yeah,
so again, if in those patients that have failed those treatments, the important things, and the MRI helps let that on, that is kind of gives us more evidence of what to look for the knee, but arthritis is a big thing that we really look for, and we know that patients that have even moderate arthritis in the knee don't do as well if we go and do an arthroscopic procedure to treat the meniscus, because we find that arthritic change, those symptoms are probably at least partially coming from the arthritis. That's where things get tricky, and I end up having to have a lot longer conversations with patients about risks and benefits. You know, some people have much more mechanical catching, locking, and maybe those symptoms will get better with the procedure. But if they don't have those classic symptoms and this kind of dull, achy pain, they may not get much benefit from a surgery. And so we really have to be careful about who we decide to go and do that surgery on. Even if an MRI shows a meniscus tear, it may not be the right treatment to do surgery.
So you make the decision. Basically, it's an individual decision, not one size fits all.
Absolutely. And I see people refer to me all the time with an MRI that has that tear, and we got to go back to all those things: history, physical exam. Does everything line up as a patient that might do well with this procedure, or is it concerning that you might not have a good relief?
That's great information. Thanks for coming in and letting us know.
Great. Thanks for having me.
All righty. We'll be right back.